Hello and welcome to Season 2, Episode 58 of the Physician Assistant Exam Review Podcast. This week, we're going to be continuing our discussion of pulmonary infections. So one of the major issues with pulmonary infections that I can see, and probably infections all over, but it's coming into my head as I'm covering this particular section, is the idea that the nomenclature we use to discuss different diseases, and it's very obvious in pulmonology, the way that we do things is not the best way. It just so happens that it's the way that we've always done them, so we continue to do them that way, but that certainly doesn't make it the best way. And I think what that means, and what I mean by that is, we say pneumonia, right? We call a disease pneumonia. Well, that has to do with where the infection is. It doesn't have to do with anything but where it is. We call something bronchitis. We call something sinusitis, right? And all those have to do with is where the location of the infection is, right? You could have RSV causing it. You could have strep pneumonia causing it. You could have, all different things can cause all of these different diseases. So it's important that we understand that part of the nomenclature. But there's another part of the nomenclature, for example, tuberculosis. Well, tuberculosis is really only referring to a disease caused by one particular bug. So that's where things get a little bit different and a little bit difficult. For example, a friend of mine's mother recently, he was telling me the story. She got a cut on her hand while she was outside, and it wound up getting infected with strep. And we were actually at a little bit of a get-together with a couple of friends when he was telling this story. And everyone there was shocked. They didn't understand how that could possibly happen. They thought that was so weird. And it is a little strange, don't get me wrong, but they don't see the big picture. They don't understand that strep's just a bug, right? It's just a bacteria, and it starts to grow on a surface, and you get an infection, whether that's, usually it's strep throat, right? That's the place we most commonly develop that kind of an infection. But you can get a staph infection anywhere, right? When we cover staph, we talk about what it does in the skin versus what it would do if it got infected into let's say hardware. Let's say you fix somebody's ankle and they got a staph infection on the hardware and in the ankle, right? That would be a big deal. We don't classify it based on the location in that case. We call it a staph infection. So it's a little difficult to keep all this stuff straight because we name things differently for different reasons. It's a little confusing. And to me, it's a lot like using the English measuring system of cups and ounces and feet and miles, and it doesn't make a whole lot of sense versus the metric system. Unfortunately, we don't have a better nomenclature for naming diseases, but it's one of the reasons we get lost in the diseases. So I want to make sure that that's clear for you and you understand why that is, and some of that I found difficult to wrap my head around for a while. And another place I found difficult to wrap my head around, as we'll talk about as we go through this, that even though you come across some of these bugs, it doesn't mean that you get sick from them. And why does one person get sick from one and one not? How do you walk into an area that has TB and it's not really a big deal for you, or you get it and it's a disaster? You see patients who have pneumonia and you don't catch it. How come you don't catch it? Why does somebody else get it? It has a lot to do with your immune system at the time, right? And how your immune system is functioning and whether you can fight it off or not. If you're not in the best of health, it's harder to fight it off, right? So if you're a little older, if you're a little younger, if you don't eat well, if you don't sleep well, all those things affect your immune system and affect what your likelihood is to get a specific disease if you come in contact with that bacteria or that virus. And that's it's just difficult to get your head around. So anyway, that is my little spiel here at the beginning, because I think a lot of this stuff is tough to especially when you're new to it, to grab a hold of and really understand what everyone's talking about. You can memorize all the terms for sure, but it's hard to see the way everything works. And you'll develop that as you go. It becomes more and more clear. But I think there's definitely some shortcuts to that. So anyway, this week we're going to be talking about pulmonary infections. We're going to continue with that. And with that being said, let's go ahead and get started with our priming questions. What is the fatality rate of Ray's syndrome? What's the fatality rate of Ray's syndrome? And Why is that relevant to our respiratory discussion? Name 2 respiratory illnesses that have a cough that is worse at night. Name 2 respiratory illnesses that have a cough that is worse at night. And what is a GON focus? What is a GON focus? Hopefully we're going to clear that one up for you today, because that's one that always kills people. So anyway, let's go ahead and get started talking about influenza is going to be where we start this discussion. Influenza. So influenza is an orthomyxovirus. I'm not sure how that'll come up on your exam, but there it is. This is most commonly seen during the fall and winter. I think we're all pretty aware of that. I actually just went and got my flu shot this morning, so hopefully that'll help me in that department. Incubation period is 18 to 72 hours after you come in contact with it. The big issue here are the secondary diseases. Influenza kills lots and lots of people every year, tens of thousands of people every year, but largely because it leads to secondary infections. It leads to pneumonia. And then Ray's syndrome is also on that list of secondary diseases. So Ray's syndrome affects children under 18, and it's a disease that has a 30% fatality rate. That is a tremendous number, a 30% fatality rate. And one of the biggest risk factors for for Ray's syndrome are having had the flu or varicella and being treated with aspirin when you're under 18. And then it develops a little while thereafter. And again, it's not something I think you're going to see a ton of. It's not something you're going to see a lot of, but don't treat kids under 18 who have the flu or varicella with aspirin. That risk is just unbelievable at a 30% fatality rate for anybody who winds up with Ray's syndrome. I'm not going to go into Ray's syndrome here in any kind of detail. I just want to point that out to you so you're for your clinical practice, just to be aware of that issue. Clinical presentation of the flu, I think we're all pretty clear on this one. This one's not too subtle. One of the keys is there's that incubation period of 18 to 72 hours, but then there's a very sudden onset of symptoms. You get the fever and the chills, general malaise, so you feel like crap, and the cough, which is typically not productive. I have a little note to myself to mention, does that help if I tell you the cough's not productive? So remember, we're talking more about addressing these things as if they're test questions, and that's a major focus of the Physician Assistant Exam Scholars newsletter this month. This is the December issue, is going out shortly. Is the main focus is on working through pulmonology and working through some of these ideas and separating out the things that are valuable and the things that are not valuable. And in this case, the question here is, if I tell you the cough, which is not typically productive, it's not all that helpful to know that, because there are lots of things that have a non-productive cough. So it doesn't really help us separate it, but it's certainly part of the clinical presentation. So it's good to know, but it doesn't help you on a test question. Sore throat, again, good to know, but not helpful. Arthralgias and myalgias. You don't get a lot of respiratory infections that have arthralgias and myalgias, so you might want to pay attention to that. Nasal congestion, eye pain, photophobia, and possibly GI symptoms, depending on the strain. Lab studies and physical exam findings. You can get wheezes, may be present. The virus can be cultured in a few days, and a rapid antigen test are available, but mostly it's a clinical diagnosis. Treatment. Number 1 should be what I went and did today, which is an annual influenza vaccination for everyone older than 6 months of age. My hospital requires it. In fact, in the next couple of days, if I hadn't had it done, they would not let me come into work. So I went ahead and got that done, and I'm going to bring the paperwork in tomorrow. So getting your influenza vaccination is extremely important. So mainly it's going to be supportive care. So making sure you get lots of fluids, lots of rest, that sort of thing. Tylenol to treat the fevers, not aspirin. And there you have it. There are some medications for this. So you have zanamivir, which is known as Relenza, and oseltamivir, which is Tamiflu. These are contraindicated in children under 12. That's a red flag I'd put up there, because that's an easy test question to write. Contraindicated in children under 12. They are expensive. They also must be started within the first 48 hours of infection. And they've been shown to shorten the course of the flu by a day or so. So they can be helpful. And most importantly, this is not for your healthy 22-year-old who gets the flu necessarily. This is more for your elderly patient who already has a little bit of a weakened immune system, your little kid who already doesn't have a ramped up immune system. Not little kid, I'm sorry, they're contraindicating kids under 12, I just said that. But in someone who you think may have an issue fighting this off, it's probably a good idea. Next, we have pertussis, and this typically occurs before 2 years old. And that's a key, right? Not a lot of these are affect this specific age group. So if you see this specific age group, you can think a little bit toward pertussis. This is caused by Bordetella pertussis, a gram-negative coccobacillus, and it's spread by respiratory droplets and is highly contagious. That's the key here. It's super contagious. I've written in my notes that it has a severe off. Let's put a C in front of that. A severe cough for weeks, which tends to be worse at night. It tends to be worse at night. They get tearing, sneezing, malaise, and the real hallmark for pertussis is that rapid consecutive cough. I've heard it referred to as a staccato cough. This is followed by deep inspiration with a characteristic high-pitched whoop, which begins a little later. So it's really that high-pitched whoop. So this is also known as whooping cough because it has a very distinct sound to it. So if you're going to get a question on this, it should include that, you would think. One of the questions I asked early on is, can you come up with a couple of respiratory diseases that have a cough that's worse at night, right? So this is one. You get a 2-year-old with a cough that's worse at night for weeks. You start to think this may be pertussis, right? Okay, so that's one. Another one is asthma is the one that comes to my head. If you hear of a cough that's worse at night, I'm thinking asthma. Now, I know cough isn't necessarily the number one symptom for asthma, but increasing night respiratory symptoms, that pushes me in that direction. Can you think of 2 others? I have 2 others that I think could be worse at night. Maybe different age groups, but certainly may have a cough that's worse at night. One is allergies. Could be worse at night, depending on what's in the bedroom. If their kid sleeps with a cat or a dog, certainly possible. Not something I wouldn't write a test question that way. I think that's probably pretty mean, but it's certainly possible. And then to me, CHF is another one. And once they're lying down, right, you get that paroxysmal nocturnal dyspnea, so you can get a little bit of a cough that's worse at night. Probably a question written in a different manner, but that's certainly a possibility and how I think about these as I go through them. All right, where were we? Under pertussis. There we go. So those were our clinical presentations. Now labs and studies, you can do viral cultures, and a PCR is the most sensitive way to test for this. Treatment. Well, first we're going to start with our vaccination, which is available as part of the Tdap, and a booster vaccination is recommended for all adults. I have a little note in here too. I just wrote in booster vaccination is recommended for all adults. I didn't put in there all adults over X amount of age because I don't think that's relevant information. I want you to start seeing how to think about this stuff from a testing perspective. Memorizing that anyone over 48 years old or born after 1972 should get a booster shot. I don't even know what those are real. I'm just making them up. Isn't helpful, right? They're not going to ask you a question. If they do, it's downright mean about the specifics of a pertussis booster shot. That seems extremely unlikely. And since there's only so much material you can hold in your head, I don't think it makes a lot of sense to make that one of those things. So to me, I remember there is a vaccination available, and as I get older, I should probably get a booster shot, which you get when you have kids. You get that, so it certainly helps. Anyway, treatment would be macrolides, erythromycin, azithromycin. RSV is our next disease, respiratory syncytial virus, and this is an interesting one because, again, this virus can cause different diseases. So it's a weird thing to discuss, like I was talking about at the beginning. And obviously that came out as I was going through some of these respiratory illnesses because it can cause bronchiolitis, it can cause pneumonia, it can cause an upper respiratory tract infection. It is a specific virus that can cause a lot of different problems. So when we said say you have bronchitis, when we say you have pneumonia, those are places. They are not bugs, right? So just try to keep that straight. This is the most common cause of a lower respiratory infection in children, and it most commonly occurs in winter. When I did my pediatrics rotation, I did an inpatient pediatrics rotation, and the halls were lined with kids with RSV infections. I mean, absolutely every room was packed with these snotty, runny-nosed, poor, absolutely horrible-looking little kids, and they were all there for RSV. It was really, really bad. So just something a picture you can hold in your head are the little kids in their cribs in the hospital, just snotty, yucky messes who are being monitored because their oxygen levels can get bad. They have these coughs, they can get pneumonia, like you said. So this can be pretty nasty depending on the situation. And this is a common cause of infection in immunocompromised patients just because it's so ubiquitous. The bug is everywhere. This virus is all over the place. So clinical presentation depends on the site of infection. I just talked about you can get an upper respiratory infection, you can get bronchiolitis, you can get pneumonia. All of those will have different symptoms of which you can probably picture in your head. Lab studies and physical exam findings. Pulse oximetry is going to be a key here, especially if you're looking at hospitalizing somebody. The virus may be cultured, and there is a viral antigen identification process. Treatment is really, you can go ahead and do all those, and they do test for it, but the treatment is really supportive care. So it's fluids, use of humidifier, a ventilator, use of humidifier, and then worst case scenario, obviously, is a ventilator if they really have that much trouble breathing. Now, for the last one for today, I want to talk about tuberculosis. And I want to take a minute and sit on this one for just a second. TB is caused by Mycobacterium tuberculosis, by definition. There's a couple interesting things here, and I want to take a minute to sit on them. So I will go through, like we normally do, the presentation, the treatments, the testing, all that stuff. But there's a little bit more to this story that I want you to understand in order to get these questions right. I don't necessarily think the information is entirely relevant for you, and I would skip it, except I think it's so easy to ask test questions on that you need to have a basic understanding of it. So one of the interesting things about TB is most of the people who get it will clear it. You'll get it, you'll have kind of like flu-like symptoms, and then it'll be gone. Some of the people who get it will get it, and then your body will, within the lung, will wall off the area where the tuberculosis is, where the bug is, where the Mycobacterium tuberculosis is sitting. It will wall it off. But it won't eradicate the disease. This is called latent disease. What happens later on down the road is, for some reason, like we said before, why you get pneumonia, why you get something else and nobody else does, your immune system becomes compromised in one way or another. I'm not talking about getting HIV. I'm not talking about something as drastic as that. What I'm talking about is you get older and your immune system weakens a little. You get sick with something else and your immune system's so busy fighting that you don't have enough energy to fight the TB anymore. So that latent disease turns into active disease and starts to spread within the lung and possibly out to the rest of the body. So we have the ability to clear it. We can have latent disease and we can have active disease. And in addition to that, I guess we could have primary disease, that primary infection site. So part of understanding TB is understanding that pathway, that it's not just a one-time deal. It almost works like varicella zoster, right? So everybody seems to get that one for some reason and struggle with TB. Varicella zoster is a virus that causes chickenpox. And then your immune system clears the chickenpox, but it doesn't clear the virus. The virus continues to survive within the nerves. And then at some point down the road, whether it's because of stress, I've seen that in younger people, or as you get older, which is more common, your immune system weakens for one reason or another, and the virus comes back as shingles. This is not a new infection with the varicella zoster virus. It is a latent infection turning to active infection. I had an amazing story when I worked in foot and ankle of a woman who came into our office and just made this super clear for me for maybe the first time ever. She came in because she had foot problems. Well, we took an x-ray of her foot, and it wasn't subtle why she had problems. She had shrapnel completely filling her leg. I mean, it looked like snow sprinkled across the x-ray image. I mean, it was unbelievable. And she had had surgery before, and she had some problems. This was, I believe it was during World War II. She was on a train that got blown up as a little kid. And so she had been taken care of. She'd been treated. And at the time, I mean, it was probably 70 years ago, she'd been treated for this. We wound up, so she had some scars on the lateral border of her foot from this injury. She was having some issues with the medial side of her foot. So we went and we did surgery on this particular patient. And The surgery was all medial. We were nowhere near her lateral incisions or her lateral scars. And post-operatively, the lateral side of her foot became infected and her old scars opened up. And the only conclusion that made any sense was that this was a latent infection. And she had been so compromised both by age and by the insult from the surgery we did that latent infection was no longer being controlled. That her immune system had been fighting it just enough to keep it under control. And once we had decreased her immune system to a certain point, her immune system began to lose the battle. And that's what happened. So it's tough to, like I said, it's hard to get your head around those ideas if you haven't seen them. At least it was for me. Maybe you're better at this than I am, but that took a long time for me to see clearly how the immune system gets affected by these things and how that works. So I want you to understand that TB is the same way. You can get a primary infection, which kind of has flu-like symptoms. Then it becomes a latent infection or it gets cleared. The latent infection is not a huge deal until it becomes an active infection, but only a certain percentage will ever go on to active infection. It's a small percentage too. I think it's like 5 or 10%. It's not huge, but it's enough, right? Especially if you're in that 5 or 10% group. So, and that's the group that we're looking for, is that latent active group. And here's some numbers. TB kills 50% of patients with active disease. So that's why we're so all over this. It's not because a huge number of people wind up with it, although they do, because with the demographics across the globe, it's actually a huge problem. But the number of people who get exposed to it, I guess to say, is not the number that go on to active disease is not that high considering the number of people who get exposed to it. Anyway, let me move on before I muddle that anymore. Risk factors for TB include overcrowding, malnutrition, smoking, diabetes, and HIV for the reasons that I've explained already. And the overcrowding part is just that it's infectious. So, and it's that you can give it to other people. So it's the same way that some other things would be found in overcrowding. Now, one of the things, let me see if I can make this part clear. I want to go through just a couple of definitions here because I want you to, if you come across them on your exam, I want you to know them. So the first one is a caseating granuloma. You'll hear the term TB, caseating granuloma applied to TB. Actually, let me back up just one second. A granuloma, let's just start with what a granuloma is. A granuloma is when an infection or something that can't be cleared by the immune system is walled off within the body. So it gets packed with white blood cells around it as sort of a wall or a barrier between that foreign object, that invader, and the rest of the body. That's a granuloma. A caseating granuloma is a granuloma where the stuff on the inside dies due to necrosis. And then if you cut into that granuloma, let's say you have somebody who died of TB and you cut into their lungs and you find this granuloma, this mass, and you cut into it, it looks like rotten cheese, which is where caseating comes from. It has to do with the word cheese. So when you cut into it, it's disgusting, right? So that's a caseating granuloma. So TB, what happens is it gets into the lungs, and if your system can't clear it right away, it starts to create, after a few weeks, this granuloma. And then we call it a caseating granuloma because the material inside dies and gets gross. A Gone focus is the caseating granuloma of tuberculosis. So it's just a specific name for a caseating granuloma as it applies to TB. You can picture a caseating granuloma could apply to lots of places. A granuloma could apply to lots of places. But a Gone focus refers to specifically the caseating granuloma of tuberculosis. So now we're just getting into more specific names. But I know you hear the term Gone wrong complex, and then how does that apply to TB? So that's why we're going through this. Now, the Gone focus is that caseating granuloma. The Gone complex is the Gone focus plus the nearby lymph node, which has picked up some of the TB, and there's a caseating granuloma forming there as well. So you have the initial primary site plus the lymph node that's been infected, and that's where you get the Gone complex. Now we're going to make this just slightly more complicated, just a little, not much. The Ronc complex. The Ronc complex. Over time, you can picture that Gone complex, which is that wall of white blood cells around the TB and around the lymph node containing the TB. Becomes that area becomes fibrotic and calcified. And then, excuse me, then you can see it on X-ray. And that's the RONC complex, is that calcified fibrotic GON complex. So we call them a GON-RONC complex is also reasonable, right? Because they are this, a RONC complex has to be a GON complex, not vice versa. And I hope that I don't want you to get too muddled into that, but I want you to observe those terms and not get freaked out by them. They're actually pretty straightforward if you take a little time to think about them. But those appear in that latent disease. Anyway, clinical presentation. A chronic productive cough with blood-tinged sputum, fever, drenching night sweats tends to be the keyword here. Weight loss is another good keyword. Lab studies and physical exam findings. You have a tuberculin skin test with normal, healthy, low-risk person is a positive test at 15 millimeters of induration. All of you have probably seen this. The healthcare workers or moderate risk patient has a positive at 10 millimeters of induration, and immunocompromised patients consider positive at 5 millimeters. So we're testing for that latent disease. Chest x-rays, findings and location change based on the stage of the disease. This is something I didn't get until this time going through the notes. I've gone through this hundreds of times, and I have always missed this. The chest x-ray I always had as being an apical issue in the lungs, and I found out that that's not 100% true. It is primary disease is more likely to be found in the middle or lower lung field. So those GON-RONC complexes are more common middle or lower lung fields, but the reactivation things that you'll see, the changes you'll see would be in the upper lung fields up by the clavicles, which is always the term that stood out to me as looking at the clavicles for a TB on an x-ray. But that's apparently just in the active phase, and not in that latent phase where you get those GON-RONC complexes more in the middle or lower lung fields. You can also do an acid-fast bacillus stain for the sputum, and you can do TB can be cultured, but it's slow growing, and will take 2 to 6 weeks to grow out. Treatments for tuberculosis. A vaccination is available, but provides inconsistent protection. And it's used in many parts of the world, but in North America, it's only used for super high-risk people. And, excuse me. And one of the problems is once you get the vaccination, you turn up positive on the skin test. I had a girl in my school, in my PA class, who was from Ghana, and she had received that vaccination. So every time she gets the tuberculin skin test, it comes back positive. So she's got to sort of explain that away a little bit. Okay, where were we? All cases of TB are reportable, and non-adherence to treatment plan is a major cause of treatment failure. Direct observation therapy is often recommended. I'm pretty sure most people kind of get that unless you're hearing about this disease for the very first time. The initial 2 months of treatment is known as the intense part of the course, which is you take all 4 first-line antibiotics. You're going to enjoy me trying to pronounce these. Isoniazid, rifampin, pyrazinamide, and ethambutol. I'm not going to do it again. You know what they are. You can go look them up. You don't have to hear me stumble through them. Over the next 4 to 7 months, typically we get rid of pyrazinamide and ethambutol. Those are discontinued. And the reason for that is the sensitivities are now back, and we can adjust the antibiotics to a more appropriate treatment. We will, or you should rather, repeat the cultures and monitor them. You should repeat the chest x-rays and monitor them to make sure the treatment's working, and monitor symptoms, obviously. One of the issues with TB medications is the side effects, right? So if you're on these 4 kind of powerful medications, they certainly have side effects. That's one of the reasons why non-adherence is an issue, although just non-adherence in general can be an issue. I know if our kid gets an ear infection, we have trouble finishing the antibiotic course. Once he feels better, you sort of, it's hard. You forget. With this kid, it's far more important with TB to make sure that people finish the course, because that's how we get resistant TB, right? So isoniazid, it has peripheral neuropathy is the main one there. Hepatitis is another, and rash. Rifampin, you get orange body fluids, flu-like symptoms, and hepatitis. Pyrazinamide, you get arthralgias, hepatitis, and GI issues. And ethambutol, optic neuritis, tends to be the one that jumps off the page as far as a easy test question. So those are the reasons people might not want to take those medications. So anyway, that is the end of our discussion for today on pulmonary infections. One of the things in our study tip for today is again, I'm just going to point out, continue to look for those places where diseases stand out. Continue to look for the places where you can identify specific diseases and how you can separate out things based on the symptoms. Diagnosis is going to be the most important thing on your exam, and you're going to want to be able to figure out how to separate certain diseases from other diseases. You're going to want to do that while you're studying. And like I said, this comes to mind because that's what I wrote the December issue of Physician Assistant Exam Review Scholars newsletter is all about, is how to do that, how to, especially